We all know the exact and complete definition of the operative dentistry given by Sturtevant. With respect to that, when we look into the gingival tissue management, probably the first bell that would ring would be the harmonious relationship with the adjacent soft tissue. To be more precise, any restorative procedure that is done should never leave a negative impact on this tissue. Now, maintaining this harmonious relationship is never an easy task, but then still we try our level best to maintain an harmonious relationship in our lives by understanding what we are going to deal with. There is nothing different when it comes to gingival tissue management as well. The adjacent soft tissue, what we are speaking about here, is represented in this picture, out of which the zone 2, that would be the sulcular epithelium, is the type of tissue that has to be deflected during a restorative procedure. Now, more importantly, is the soft tissue that we are not supposed to deal with, that would be the junctional epithelium. So, the highlight is that during any gingival displacement method, we should make sure the junctional epithelium is never disturbed. Now, the junctional epithelium is the soft tissue that adhere with the tooth structure by itself. This is composed of something called as the dentogingival unit, which facilitate this. Now, during any gingival displacement, the idea is that it should never leave any scar on this tissue, and rather, this dentogingival unit should never be disturbed. Next fact that has to be put forward here is the biological width. Now, this is a age-old concept, and we would have heard that we should never violate the biological width during a restorative procedure. Now, biological width is nothing but the sum of both the junctional epithelium as well as the connective tissue. So, the thickness of both of this together forms the biological width. Again, a lot of studies, early 60s, they said that the junctional epithelium is lesser compared with the connective tissue. However, the studies which was published after 1994 and all that said the junctional epithelium is more compared with that of the connective tissue. Now, this is one school of thought. Now, there is another school of thought. What if the biological width is already violated during the disease process? So, this is the concept which Pascal Magny and many other authors, such as Andre, is looking into it. Now, they say that if the biological width, in case if it's altered, violated by a disease process such as dental caries, we can still go ahead and do a restoration. And they say that there could be a junctional epithelium reattachment that could happen between the junctional epithelium with that of the lithium disilicate or composite or any restorative material of that sort. Now, this is just a concept, and they say that this has happened, but they also say that the literature on this particular aspect is quite minimal, and a lot of researches has to be done on this field. Now, there's just a school of thought, and there are these two school of thought when it comes to biological width, and I want to make sure that you know and know to write on both of these school of thought. This is mainly because exam perspective for all the postgraduates, you could expect a question on how to critically analyze the biological width, and in that case, you may have to write both the school of thought, and you need to know the men and work on both school of thoughts. Now, the goal of gingival displacement. So, the goal is definitely to deflect the sulcular epithelium or the gingival sulcus away from the tooth, and how much away would be 0.2 millimeter. Some of the articles, or probably the literature, also gives this figure in a different unit, and they would have mentioned as 200 μm. It's also the same. Now, why this retraction? So, this 0.2 millimeter is quite good enough for the gingival this 0.2 millimeter of gingival deflection is quite good enough for the impression material, such as here in this case we could say additional vinyl polysiloxane, to go record that finer details and come out without distortion. So ideally, for that to happen, at least we need about 0.2 millimeter of that thickness. And the second objective of any gingival displacement should be be the fluid control. Now, for example, we'll again speak about the vinyl polysiloxane impression itself. This is quite hydrophobic in nature. So in case if there is a moisture contamination that happens within the sulcus, the vinyl polysiloxane is not going to flow in there and record those details. So definitely the area should be dry so that the impression material could go and record. Now, the gingival displacement is not just during the impression, it is also advisable to deflect the gingiva during tooth preparation and also cementation. The position and form of the gingiva should also be taken into consideration while doing selecting a gingival displacement method. So that would be done both radiographically as well as based on clinical examination. Now, the most important part when we choose a gingival displacement method, the gingival displacement should be based on a concept called as gingival biotype, or pre-treatment periodontal health biotype should be considered. Now, there are a lot of studies which have evaluated the biotype, and a lot of classifications are also given by various other authors, out of which the most accepted classification is given by Clifford Oceanbean. According to him, there are only two different types of biotype: the thick flat biotype and the thin scallop biotype. Now, the flat biotype is the biotype what we want for the gingival displacement to happen well, and the thick flat biotype is more favorable for doing a mechanical gingival displacement. For a thick flat biotype, the gingiva is usually thicker and fibrotic, increase in quality and quantity of masticatory mucosa, increased probing depth, and gingival margin will be on the enamel per se, and the distance between the cemento-enamel junction and the bony crest should be about 2 mm, and the underlying bone has a limited scalloping, and no bony dehiscence and fenestrations would be present. Where in case of thin scallop gingiva, there would be a limited amount of attached gingiva, probing depth is shallow, gingival margin and cemento-enamel junction would be on the root surface. There would be increase a radiographic difference between the cemento-enamel junction and the bone of approximately 4 mm or so, and also the bone is scalloped and bony dehiscence and fenestrations would be present. Now, the thin scalloped gingiva is never considered as a healthy gingiva. Usually it is a condition which is seen in gingival recession. So you're opting for a gingival displacement mechanically, that would be to go ahead with a thick flat gingival biotype, and make sure you understand exactly what the clinical features are looks like for a thick flat gingival biotype exam perspective. The definition: the gingival displacement is defined as the deflection of the marginal gingiva away from the tooth. Marginal gingiva, sulcular gingiva, gingival sulcus, sulcular epithelium, it's all the same. So you deflect it during a restorative procedure is defined as gingival displacement. Now, there are some of the questions could also be asked as gingival retraction. It would be also the same. And speaking about the classification, there are about 7 classification, very common 7 classification. You just have to go through it. The references would all be provided at the end of the session. So these are the 7 classifications. Now, this is per se not a classification. This something caught my attention. This is actually a data representation given in a systematic review. Now, we'll discuss towards the end about the systematic review. However, in case some of the universities still have habit of asking a massive 100-mark question on a topic, and in case if this topic has been asked as a 100-mark massive question, then you can represent the entire data on this format. So this something that looks like a classification has actually classified the entire gingival displacement method in a sequence, and this would be advised. This way of representing data would be quite attractive for the examiner who corrects. Now we'll start with mechanical gingival displacement. The thing about the mechanical gingival displacement method is it's quite effective, which means you do deflect the gingiva. For sure the gingiva is going to get deflected the way we want and how much ever we want. Now, out of which this is a displacement method done by Brinker gingival tissue retractors, which you could see on the in the picture. This is used along with the conventional rubber dam isolation kit. So here the clamps go ahead and get engaged with the tooth structure by itself, deflecting the sulcular epithelium or the gingival sulcus. Next is the socket shield retractor. This consists of a crescent shaped head, as you could see in the picture, and it is attached to the handle of the instrument with a ball and socket joint. Now the ball and socket joint facilitates the instrument to deflect the sulcular epithelium the way we want, and we can angulate it. And this is usually advised for doing any tooth preparation subjectively as well as during cementation. The another one is the gingival traction tool. This was originally used for implant dentistry, but then, however, its usage has been indicated in the field of operative dentistry as well by Charles J. Goodacre. The hero would be the gingival retraction cord for gingival displacement. This is a short question for Viva Voice. There are about 5 classification for the gingival retraction cord. Depending upon the configuration, it could be plain twisted, braided or knitted. Depending upon the surface finish, it could be waxed or unwaxed. Depending upon the chemical treatment, it could be plain or impregnated. Depending upon the number of strands, it could be single or double. Depending upon the thickness of color, the most commonly used classification applied for gingival retraction cord, that would be black 000, yellow 00, purple 0, blue 1, green 2, and red 3. Now there are very many other classifications as well, given by various other authors, and if it could be included, you can include that as well. The other one is the cord packing instrument. Fisher cord packer would be a gold standards, but more importantly, which cord packer goes with what kind of retraction cord. Now, the serrated retraction cord packers are usually indicated for the braided retraction cords, wherein the smooth retraction cord packers would be indicated for the knitted retraction cord. So, in case if you're interchanging, if you're using, let's say, smooth for the braided one, it is going to slip off from the retraction cord by itself, and it's never gonna place the cord into the sulcus. Whereas the other way, if you're using serrated for the knitted one, the serration is going to get tangled with the knitted retraction cord, and it's gonna come out along as you pull the retraction cord packer away. So never interchange, make sure it is used for the right retraction cord. The other one is the periodontal probe. The usage of periodontal probe is also indicated in Schellenberg for the placement of retraction cord. I'm not asking you to use it, but make sure you know this literature. And also there is an instrument called as Greg Fofi instrument. This is the word which is again given in Schellenberg. Even it was new to me that the plastic filling instrument is otherwise called as Greg Fofi instrument as well. Various other retraction cord packers given with various striations are also used for gingival cord packing. So you can go ahead and find a retraction cord packer of your choice. But the golden rule: braided, go with the smooth one; braided, go with the serrated one; and if it's a knitted retraction cord, always use a smooth gingival retraction cord packer. The next one is how much force you have to apply while placing this retraction cord. Now, if you look into it, I have used the word placement of retraction cord into the sulcus. This is the way to convince ourselves to the fact that we should not apply more amount of force. There are another term they probably use for the placement of retraction cord, something called as cord packing. Even for the instrument, we call it as cord packer. Now, convincing yourself to the fact that you pack the retraction cord into the sulcus is quite tragic if in the way that you are kind of applying more force to pack the retraction cord into the sulcus. I wouldn't do so. So the way we could portray this would be in a lighter way, placing the retraction cord into the sulcus. This is softer way of dealing with it, because we all almost need only about 0.25 to 75 newtons of per millimeter square of force, all we need for placement of retraction cord. But the ugly truth is we almost use about 2.5 newtons of millimeter square per millimeter square of force. Now uh, damage is expected to happen after 1 newtons per millimeter square itself. So if you're giving about 2.5 newtons per millimeter square, it is for sure that you rupture that junctional epithelium, which we spoke in the first case, in the first slide. Now, this can be self control. We should have a self control of what this force is. Now, there is an instrument which is called as pressure sensing probe. This is quite commonly used in periodontology. So this even comes in GDC for about $700. So you can use this periodontal probe, practice yourself, and understand what this 1 Newton per millimeter square of force looks like and feels like. So have a better digital tactile on this 1 Newton per millimeter square of force. Apply it on the cord packing instrument, and make sure you don't exceed this 1 Newton per millimeter square of force while placing the gingival retraction cord. Emphasize placing the retraction cord into the sulcus. If you do so, you can prevent gingival recessions. Then would be the principle of gingival, the sulcular displacement would be retracting the sulcus, doing the procedure, and when the minute you remove the retraction cord or probably any other gingival displacement method, the sulcus should relapse back to its origin. Now, there are different techniques for placing the gingival retraction cord. The most common method would be we use is single cord technique, but then I'll speak more about it, and I'll tell you when exactly to use the single cord technique. However, exam point of view, make sure that you write these points such as length half an inch longer than the circumference of the preparation. Start packing from the mesial interproximal area. As cord placed, subgingivally instrument should be pushed slightly towards the area already tucked in, and also make sure to hold the retraction cord with one instrument while packing with the other. Instrument angles towards the root facilitate subgingival cord placement. Cut off the excess cord in mesial interproximal area. Finish the placement of the distal end of the cord overlapping the mesial side. Now, all these are exam perspective. In case if the question has been asked on single cord technique or double cord technique, make sure you write all of this. Okay, even for the double cord technique, you have to follow this repeatedly, and that becomes your double cord technique. But clinically, make sure that you start from the mesial side, end at the mesial side. That would be good enough. Whatsoever we tell, and cut off the excess, that would be good enough to remember clinical perspective. Now, whatever we speak about it, you're going to do what you're going to do. But more importantly, it's about the force and how you deal with placing the retraction cord inside the sulcus. The double cord technique, it is another important question. The other name for double cord technique is technatal technique. For the double cord technique, we use two different types of gingival retraction cord. The first one would be a braided, followed by a knitted retraction cord. Now, the braided is usually indicated for the vertical displacement, and the second retraction cord which you're going to place into the sulcus, it's the one which is basically used for the lateral displacement of the gingiva. Now, every other tooth technique, this is a technique which is usually indicated for multiple tooth preparations such as veneer. So here the picture, I could not get the exact picture for the every other tooth technique. What I mean from the picture is that whatever the into mark have been put, consider only those tooth we put the gingival retraction cord, take an impression, and then the other tooth, the alternate tooth which were not previously displaced, Now, the gingival retraction cord would be placed on the other tooth, alternate teeth. After removing the previously placed retraction cord, you take the second impression in this stage, and that some of the case reports even says that you require a third impression without any gingival retraction cord itself. Now, that would be every other tooth technique. Every other means every alternate other tooth should be retracted and then take an impression at each step. Now, this would be advisable if there is prominent interdental papilla, and also this facilitates to avoid strangulation of the interdental papillae during the process of recording the impression, and also the black interdental triangles could be avoided during the placement of the final restoration. Selective double cord technique. Here the first cord would be placed, and wherever there is bleeding spot, the second cord will be placed on those bleeding spots alone. The single cord technique, a critical evaluation of all the four techniques. The single cord technique is usually indicated where we require only lateral displacement of the sulcular epithelium. Now, where that would be if the finished margins are at the supragingival level and or at equigingival, then we can go ahead with single cord technique, because we require only lateral displacement in this case. Wherein if you're extending the finished margin subgingivally, in that case we require the vertical and lateral displacement. That's when double cord technique comes into place. The every other cord technique would be for multiple veneers, and selective double cord technique would be where there are excessive bleeding. Okay, so normally for the exam perspective, if you're doing a cast post for your final exam, normally you do it on an anterior, and the finish margin of choice would be subgingival finish margin. So in that case, double cord technique would be indicated, as you require you require both the vertical as well as the lateral displacement. We'll speak more about that towards the end. Now we'll speak about the cordless technique. The most commonly used cordless technique would be the Expaxil retraction paste. It consists of kaolin, aluminum chloride, oil of lemon as a flavoring agent, water for consistency, colorant for distinguishing the retraction paste from that of the gingiva. Now there is something called as Expaxil Exact. Previously it was coming as one big pack of it, wherein here now it would be pre-proportioned capsules where only required for a single tooth impression, a retraction would be dispensed. Now more about the kaolin. This is kaolin is hygroscopic in nature, which means it expands in the presence of moisture, and it is usually injected into the sulcus, and in the presence of moisture which is present in the sulcus absorbing, it expands, deflecting the gingiva. It also consists of aluminum chloride, which would be an astringent as well as hemostatic agent. This leaves the operating field or the sulcular epithelium dry for the vinyl siloxane impression paste to go there and record the finer details. Next would be again a mechanical gingival displacement. This is called the Compricap. This is probably inspired from the conventional copper band technique. So this is anatomically formed compression caps, thin firm walls, and has a deep hollow core. It is quite easy to place. You place it on the prepared tooth, ask the patient to bite on it about 3 to 5 minutes, and the biting pressure exerted would be retracting the marginal gingiva, and it is used quite commonly along with a form code. So the magic form, it goes well with the Compricap. So this consists of vinyl polysiloxane material, and it said that it expands about 160 percentage during the setting. Now the thing about the great advantage of magic form, which is made up of vinyl polysiloxane impression material, is the fact that again it goes well with the polyvinyl siloxane impression, light body impression material, addition silicon. Now this is never going to have any negative impact, unlike aluminum chloride and all that. So absolutely a big S if you're using addition silicon to go ahead with a magic foam cord. Now, when to find an alternative? That would be definitely you. Your conventional retraction method is not good enough to deflect the sulcular epithelium. Then we have to look into the alternative. Or one of the alternative would be to chop it off and then go ahead with uh, the restorative procedure of choice. Now, this chopping off could be done by a surgical method. We could use the conventional surgical method as well as the other surgical methods such as electrosurgery, which is otherwise called as surgical diathermy, lasers, and so on and so forth. Now, the electrosurgery, you have to study the basic mechanism, how the electrosurgical unit works. It's all given in detail in both Marzuk and Textbook of Operative Dentistry by Vimal K. Sikri, and all the different phases that goes through during the electrosurgical procedure. So that has to be also read from the same book. Clinically, as far as clinical skill is concerned, this electrodes has to be handled with a very light pressure. The best way to practice is to by drawing a line using a painting brush without bending the tip of the brush, the paint brush. So that exactly only that much of pressure should be given to these electrode while doing the procedure. Now, the other clinical tip would be if the electrode is dragging and if there is shreds attaching to the electrodes of these clinging tissues, which means the setting is really low, then we have to increase the setting and go ahead with the procedure. And in case if there is tissue stars, and if there could be sparking, then the settings are quite high. So then in that case we have to reduce the setting. Now the thing about the electrosurgical procedure is that the patient could quite get traumatic due to the fact that the patient's own tissue getting charred is felt and smelled by the patient. This could be avoided by making the patient more comfortable by applying a strong essential oil on the patient's nasolabial fold. The electrosurgery is strongly contraindicated in patients with cardiac pacemaker, TENS unit, insulin pump, as well as deep brain stimulators. It should be avoided with the use of nitrous oxide sedation, and also if you're using ethyl chloride as an anesthetic agent. The high volume vacuum tip should be always plastic. The tongue depressor should be wooded tongue depressor. The mouth mirror should not be a metal one. We have to go ahead with a plastic mouth mirror, and it could be more conductive, and more importantly, the cottons used for isolation should be moist. Next is the working principle of lasers. Especially for gingival displacement, we do a procedure called as laser troughing. Now again, with the we need to know the working principle of laser. It could be asked as a short note, the laser gingival displacement. In that case, you need to start with working principle of laser, mechanism of laser, and then go ahead with the other aspects of it. So when it comes to laser, you have two different types of contraindication. The false contraindications or the myths that says that the laser should not be used with a pacemaker, photosensitive patients, and patients with a deep brain stimulator. Wherein the actual contraindications are only when the patient is when there is a clinically active malignant lesion, active bleeding, the patient who are pregnant, and right over any pathology on the soft tissue. Now, chemicals used in gingival displacement, there again three classifications of it. just go through the classifications. Then the class then would be the epinephrine. Now, the thing that you need to remember about the epinephrine is the epinephrines are no longer used for gingival displacement. Now, there were a lot of reports that there were a lot of usage of epinephrine in early 60s and 70s in clinical practice. There were even studies that says that 53-63 percentage of epinephrine were used for gingival displacement. However, long story short, it is no longer used for gingival displacement due to something called as epinephrine syndrome, where the patient would lead to tachycardia, increased cardiac output, tachypnea, where there is increased respiratory rates, hypertension, and anxiety. So let's see of epinephrine from gingival displacement, and then the hybrid technique. Now, hybrid technique is not a technique which is given in any of the literature or the textbook, but hybrid technique is the most commonly used technique in the clinical scenario. Even a simple retraction cord which is impregnated in one of the chemical agent, so let it be a vasoconstrictor or a hemostatic agent, then that becomes a hybrid technique. Or if you're clubbing the electrosurgical technique with a retraction cord later for the further displacement of gingiva, that again becomes a hybrid technique. So this is usually a combination technique of more than one. Now, this is a randomized control trial. Now, this study is published in Nature Journal. Now, I'll speak more about it and why I've chosen this study to be in this presentation. Now, here in this study, they have used merosyl strips. Now, merosyl strips is nothing but a synthetic material chemically extracted from a biocompatible polymer. It's net-like strip without debris or free fragments. Now, this is not something new to gingival displacement. This was introduced in early 90s itself. Now, I meant the introduction of this merosyl strips into gingival displacement. Now, even before that, it was being used in otolaryngology for nasal packing and all that. Now, the highlight when it was first introduced was the fact that there were no debris during the gingival displacement. However, it got faded out, and then after a long time in 2025, the study is being published in the current issue of Nature Journal. Now, here they have compared it with the knitted retraction cord. So the sulcus one is displaced with the the merosyl strips are used similar to that of the gingival retraction cords. So into the sulcus this has been packed, and then they have measured for how much displacement has caused. And however, in the study they proved that the merosyl gave a better displacement, lateral displacement of the sulcular epithelium compared with the knitted cord. Now, the thing about this study is that they have only measured one parameter, that would be that was the lateral displacement of the marginal gingiva. Now, this wouldn't be considered quite good and ethical. We don't know the other aspect and what are the negative impact it has caused to the gingiva. Now, I was speaking about again, I want to emphasize the fact that when you do or choose any gingival displacement method or technique, it should not leave any scar to the junctional epithelium. So in this study, they haven't evaluated the post effect that has caused onto the junctional epithelium following the gingival displacement technique. So that parameter has totally neglected in this study. Where in this study they have taken that into consideration as well. So however, in this study there are three groups. This is again a comparative randomized clinical trial. So here this is published in 2025, the current issue of Journal of Prosthetic Dentistry. So here they have compared Raistel and Raistiptine. Now here Raistel and Raistiptine, the composition is almost the same. It is 23% of aluminum chloride. Now the only difference is the raised gel is comes as a gel, wherein raised diptin comes as a solution, which means raised diptin has to be saturated in one of the retraction cord and should be placed into the sulcus to make use of it. Wherein raised gel here in this one is used in a combination method where a single cord is placed into the sulcus and the remaining sulcus is filled with raised gel. Wherein the another group of raised gel, it has been taken as a cordless group where the raised gel alone has been injected into the sulcus. Now all the three groups have been compared, and here the clinical assessment of the gingival tissue is done at 7th and 14th day. And also the assessment of the patient has also been done. That would be the clinical assessment and the patient comfort assessment. So that was also taken into consideration. And finally, the qualitative assessment of the gingival displacement is done by the investigator. So here all the three parameters has been taken. So the gingival displacement has been, I will just sum it up. The gingival displacement has been measured, and then post-operatively all the candidates were again recalled to assess if there are any negative impact and caused during this gingival displacement method by clinically assessing the gingival tissue at 7th and 14th day. And also the patient has been asked for the patient comfort. So this would be a more valuable study in terms of understanding what the gingival displacement were looking like. This would be a better protocol to follow. However, this concluded saying that all the three techniques of gingival gave a lateral displacement and was greater than the required clinical value of 200 μm. The cord methods revealed higher sulcus opening than the raised gel cordless technique, and no significant difference in the vertical gingival displacement were found among the three methods. And also the efficacy of these techniques was confirmed with achieving hemostasis as well. Now the next one, the first I spoke about of representing the data, right, for a massive 100 marks. So that was inspired by this systematic review. Here in this systematic review, the PICO guidelines, the population were of course this healthy, systemically healthy individuals. The intervention was all the gingival displacement methods compared with laser troughing, and the outcome which was included were the patient comfort, the operator comfort for placement of gingival displacement or adapting the gingival displacement system, then how much was the gingival recession rate following the gingival displacement. So all the three important parameters have been included. So I repeat again, how much gingival displacement has happened, what was the patient's level of comfort, what was the operator's level of comfort, and did it cause any harm to the gingival tissue. So which means post-operatively were there any recession, or if there is any harm, negative impact on the gingival epithelium. However, the systematic review came up with an amazing conclusion saying that the laser troughing was better than all the methods of gingival displacement. Okay. Next would be, this is something which I found in Journal of American Dental Association. So here they have listed some advantages and disadvantages. It's fairly a classic article. It's nothing. It's not a present article though. I think it was published in the year 2008. Next, the emphasis towards the gingival tissue management and impression, digital impression. Now, some of them has a very wrong digital impression, saying that we don't require gingival displacement for digital impression. Now, this is quite wrong. In fact, we need to put in more effort when it comes to gingival tissue management in digital impression. Now, the thing about the conventional gingival displacement technique is the minute, especially let for example take a double cord technique. So you leave behind this first cord, and the minute you remove the second cord, you are going to inject the sulcus with the light body of yours. Now this prevents immediate collapse of the gingiva into the finish margin, and it is going to record that anatomy. Now that is not going to happen for digital impression. That's why this is quite complex. So there is a study, there were various studies, and they have formulated this standard operating protocol when it comes to digital impression. So first and foremost, we take an impression, digital impression per se, of an unprepared tooth. So even before we start doing a tooth preparation, we need to digitally scan the oral cavity. Now after that, the tooth which we are going to do the prep, that tooth alone has to be cut out from the pre-op. After that, we do the tooth preparation, and then we take another impression. Now this does not require any gingival displacement methods at all. So you're done with the tooth preparation, take another scan, after which you place the retraction cord, and then you take another scan. So here again, with the retraction cord, you're going to take a scan. Now the story does not end here, because of the fact that even the minute strands which are present in the gingival retraction cord is going to fall onto those finish margin, and those areas are not now recorded by the digital impression. So that has to be also recorded. So the last digital impression would be you remove the retraction cord, and immediately you do another scan as well on that particular tooth. Now the minor duty which were previously covered with those strands microfibers would be replaced with this last scan of this. So this would be the SOP for digital impression. So now you understand how complex to scan tooth prep with a digital impression. Now this is a randomized control trial which was done on gingival tissue management with a digital impression. So here basically there were 4 groups. The first one was with the retraction cord and astringent. The second group was cordless paste with astringent. The third group was cordless paste without astringent, and the last one is laser troughing. However, in this study, again, retraction cord proved to be very effective for both the vertical and lateral displacement of the gingiva, and the scan was quite good for it. There were enough of gingival retraction on both aspects, followed by magic form, expassal, and laser troughing. Now, speaking about the gingival here, again, this study is quite valid and probably more ethical because they have done the follow-up of all the participants. The follow-up here in this study was done at 7th day, 15th day, and 30th day. So here in this follow-up, they have investigated the amount of gingival recession that has happened, and based on that parameter, it was proved that the laser troughing gave the least gingival recession, followed by expassal, magic form, and retraction cord. Okay, so however, the study is quite good, and this is again published in the present issue of Journal of Dentistry. Go through it. It's a beautiful article, and you'll have a proper idea how to deal with digital impression and gingival tissue displacement. The previous SOP was also taken from the study only. Now the periodontal evaluation. So this is again must do for your clinic, for your exam case. You have to first inform for any gingival displacement per se. It should never be stopped just for your exam case. So this is again the values taken from Karansa 14th edition. 2 to 3 millimeter, it's considered to be normal. Ideally, the normal, we don't have any sulcus step. But it's totally impossible. So you have the oral bacteria commensal which is present, so that would lead to a sulcus depth of minimum of 2 to 3 millimeter, which is also considered to be normal as per the author. Now this here in this case, you can manage it with a cord retraction cord, you can either go for a single cord technique or double cord technique based upon where the finish margin is at. Now 3 to 4 millimeter, that would be considered as mild periodontitis. Again, you can go ahead with cord. Here this would be advisable to go for the double cord technique here, because the sulcus is a little more deeper. 4 to 5, this would be considered as moderate periodontitis, and you can again go for a cord here, but then there could be bleeding here and there, so probably you might have to go for a selective cord technique. If it's more than 5 millimeter, of course it is considered as severe periodontitis. You have to go for surgical and laser management. Now, things to remember for your practical exams: first and foremost, the periodontal evaluation should be done, and in case if you are doubtful, never hesitate to seek help from the Department of Periodontology. So make sure this is all done at least 2 weeks prior. Then study a proper gingival, understand what your gingival biotype of the patient is. It's not about the fracture that you are looking into and cast both the bite, vertical diamond, the overjet, overbite and all that. Please also pay attention onto the gingiva. Make sure the gingival biotype is thick, flat biotype. So, and that would be the exact biotype considered healthy and good to go for your exam. And practice with this pressure sensing probes, and you can confirm that using even a digital weighing scale and your cord packer. Understand what is that 1 Newton per millimeter square of force is like. Now, and next would be ask the patient to, you have to do a thorough oral prophylaxis and prescribe the patient with 0.2 percentage of chlorhexidine mouthwash. This is very important. At least do this for about 2 weeks prior to your exam, and the mouthwash should be used by the patient till the day of exam. There's definitely that chlorhexidine mouthwash would definitely give a good impact on the patient's gingival health. Then on the day of exam, while dealing with the retraction cord, never use a latex gloves. That is going to contaminate your gingival retraction cord. All the contaminants would be taken to that gingival sulcus, and your adhesion silicone is never going to go well with that area. So always go ahead with a vinyl gloss, so that your vinyl polysiloxane impression material will never have a negative impact on it. Now, most importantly, go for a double cord technique. So in a double cord technique, again, make sure you have both the retraction cord packers, the serrated one and the smooth one. First, you need to place a 000 braided retraction cord into the sulcus using a serrated retraction cord packer. After that, take a knitted retraction cord. Now, the size of the knitted retraction cord depends upon the sulcular width. You need to pre-calibrate and keep it how much width it is, and go ahead with choose one of the knitted retraction cord, and that has to be placed only with a smooth cord packer. Now, while taking the impression, you remove only the knitted retraction cord, leaving behind the braided, firstly packed braided retraction cord. Only the knitted one should be removed. The second cord should be removed, and then the minute you remove it, use an intrasulcular tip to inject the light body into the sulcus. Okay, this is very important. Only then you can record those finish margin. Okay. And more importantly, all this above mentioned procedure should be done under magnification. If you have an access to the microscope, please do it under microscope. If you don't have an access to a microscope, bare minimum, make sure you use loupes. The men in work would be Charles J. Goodacre and Nadeem Baba. Charles J. Goodacre has also published numerous articles on gingival aesthetics. Nadeem Baba, in spite of gingival displacement, again he has published numerous articles on restoration of an endodontically treated tooth. Both of them together has authored a very classic articles with a humongous citations, which was published in the year 2014, Dental Clinics of North America. Both of them are associated with Loma Linda University. Now, all the references which I've presented in the used in this presentation could be all scanned. Could all be downloaded by scanning this QR code. Uh, Again, thank you all for your patient listening. All the best.